I want to start today's deep dive with a bit of a riddle. Or actually, let's call it a high-stakes medical mystery. Because, I mean, the implications of getting this wrong are literally life and death. You've got the research stack in front of you. Are you ready for this?
I am always ready for a mystery. Go for it. Lay it on me.
Okay. Here's the scenario. What is the only solid organ tumor in the human body, and I'm talking about a major lethal cancer here, that we can diagnose definitively without a biopsy?
Ah.
I mean, a malignancy where you don't need to cut, you don't need to slice a piece of tissue to put under a microscope, and you don't need a pathologist to confirm the cell type. You just look at the picture and you know.
That is an absolute classic. And it's, it's a singular distinction in oncology. In almost every other field, breast, lung, prostate, if you don't have tissue, you don't have a diagnosis.
Right. Tissue is the issue.
That's what they say. But this one organ, it just breaks all the rules.
Hold on, because I've got a second layer to this riddle before you give it all away. What cancer follows a strict biological rule 90% of the time? I mean, it basically requires a specific pre-existing condition, but has one specific viral exception that just breaks that rule completely.
Ah, now you're really narrowing it down. You're talking about that interplay between the seed and the soil.
Yeah.
That's a very specific epidemiological footprint.
Exactly. Today, we are talking about hepatocellular carcinoma, HCC.
HCC, yes. The most common primary liver malignancy and, remarkably, the third leading cause of cancer death worldwide.
That statistic really jumped out at me from the source material, the third leading cause. That is just massive. We hear so much about lung cancer, breast cancer, colon cancer, but liver cancer is right there at the top of the mortality charts.
It's huge. And honestly, it's a topic that genuinely scares a lot of people, medical students, residents, even practicing physicians, because the liver is so incredibly complex. It's not just a filter. It filters, it metabolizes drugs, it makes proteins, it makes clotting factors, it manages sugar. So when it gets sick, I mean, everything in the body gets complicated. And when you add cancer on top of a sick liver, you're fighting a war on two fronts.
That's the perfect setup. And looking at our stack of sources for today, we've got these high-yield clinical guides, surgical protocols from the big associations, radiological standards. It is so easy to get lost in the alphabet soup.
It is.
I was reading through the notes, and we've got AFP, BCLC, TACE, PVE, RFA. It sounds like we're reading a secret code or, a manifest from a spaceship.
It does, doesn't it? But here's the thing, and this is what we really need to get across to you listening. This isn't just about memorizing acronyms for a test.
No.
It's about understanding the logic of the liver.
The logic of the liver. I like that.
If you understand the unique physiology, the blood flow, the regeneration, all of it, then that alphabet soup transforms into a very, very clear roadmap. It stops being random letters, and it starts being a story about how we keep people alive.
So that's our mission today. We're going to decode these frameworks, specifically what our sources call the big three: the Milan Criteria, the Child-Pugh score, and the BCLC staging. We're going to figure out how doctors take this incredibly deadly, complex disease and actually make it manageable.
And we're going to do it by starting with a concept that I like to call the North Star of liver cancer.
The North Star. Okay, point the way.
It's a simple rule, but it dictates almost everything else we're going to discuss. Screening, diagnosis, treatment, all of it. 90% of hepatocellular carcinoma arises in a cirrhotic liver.
90%, so almost all of it.
Almost all of it. And the implication there is profound. It means that if you understand cirrhosis, if you understand that scarred, nodular, damaged liver environment, you basically understand the risk profile for HCC.
You can't separate the two.
You really can't. You can't separate the cancer from the soil it grows in.
That's a great analogy, the soil. So we're not just looking for a weed growing in a pristine garden. We're looking at a garden that's already been devastated, maybe burned, maybe drought-stricken, and out of that devastation, the cancer arises.
Precisely. Let's just dig into that soil analogy for a second. In a healthy liver, right, cells regenerate in a really orderly fashion. If you cut your liver, it grows back perfectly. But in cirrhosis, the liver is constantly trying to heal itself from chronic injury, but it's failing. It forms these things called regenerative nodules. It's trying to rebuild, but the whole architecture is destroyed by scar tissue. The cells are dividing rapidly, they're mutating, they're just struggling to survive in this toxic environment. That chaotic regeneration, that's the breeding ground for errors in DNA replication. That's the bad soil.
Which brings us to the first section of our deep dive. The origins. We have to talk about how we get to that damaged soil in the first place.
Right, because you don't just wake up one day with cirrhosis. It's a process.
So we established that 90% of cases happen in cirrhosis, but I teased that riddle at the beginning about an exception, the rule breaker.
The rule breaker, yes. This is the favorite exam trap for medical boards across the world for a reason. It's a vital distinction that really catches people off guard.
It's hepatitis B.
Hepatitis B. Now, to understand why this is an exception, we have to look at the virus itself. Let's compare it to, say, hepatitis C. Hepatitis C is an RNA virus.
Right.
It lives in the cytoplasm of the cell, sort of floating around in the fluid outside the nucleus. It causes chronic inflammation. That inflammation leads to scarring. The scarring leads to cirrhosis. And then after the cirrhosis is established, you get cancer. It follows the rules.
Okay, so Hep C is the rule follower. It destroys the liver first, and then cancer shows up as a consequence of that destruction.
Correct. But hepatitis B is, well, it's different. It's a DNA virus. And it is insidious. It has this capability to integrate its own viral DNA directly into the host genome of the hepatocyte, the liver cell.
Whoa, so essentially hacking the cell's genetic code directly.
Exactly. It just splices itself right into the DNA. And depending on where it inserts itself, that insertion can trigger oncogenesis, the creation of cancer, even before the liver has become cirrhotic.
So it's an insertional mutagen.
That's the term. It can turn on cancer genes, oncogenes, or it can turn off tumor suppressor genes just by being there.
That is terrifying. So you can have a liver that structurally looks okay on the surface, no massive scarring, no nodular cirrhosis.
Right.
But because that viral DNA is integrated, you could still develop HCC.
That is exactly right. And that is why hepatitis B is the great exception. You can see HCC in a healthy carrier of hepatitis B who has no cirrhosis. It's the only major cause that behaves this way.
Which explains why, as we look at the global geography of this disease, the patterns are so distinct. The sources highlighted a real divide between East and West.
It really is a map of viral epidemiology. If you look worldwide, hepatitis B takes the top spot as the cause of HCC, largely because it's so prevalent in parts of Asia and sub-Saharan Africa.
And in those regions, it's often vertical transmission, right, from mother to child.
That's right, at birth. And that's key.
So the virus has decades to just sit there and integrate.
Exactly. If you get it at birth, the virus has 30, 40, 50 years to mess with your DNA. That's why we see HCC in younger populations in those regions.
But if we look at Western countries, Europe, North America, the picture changes completely, right?
Totally. In the West, hepatitis C has historically been the dominant driver. Although, as you know, we now have cures for hepatitis C, the direct-acting antivirals. So we're really hoping to see those Hep C numbers just plummet over the coming decades.
However, I was reading about this rising trend in the notes. It seems like as one villain fades, another one just steps right up.
That is the unfortunate reality. It's not a virus at all. It's lifestyle. It's NAFLD and NASH.
Okay, let's unpack those acronyms because they are everywhere in the medical literature now.
They are. NAFLD is non-alcoholic fatty liver disease. NASH is non-alcoholic steatohepatitis. Essentially, this is fatty liver disease linked to metabolic syndrome, obesity, and diabetes.
So high sugar, high fat, insulin resistance. The modern diet.
All of it. The liver becomes infiltrated with fat. Now, fat isn't just inert storage. In the liver, it can be toxic. We call it lipotoxicity.
Right.
That fat causes inflammation. That's the steatohepatitis part. The inflammation leads to fibrosis, and the fibrosis leads to cirrhosis and cancer. It's the same pathway, just a different starting point.
And with obesity and diabetes rates rising globally.
We are seeing a massive surge in HCC related to fatty liver. I mean, it is quickly becoming the leading indication for liver transplants in many centers in the U.S.
It's fascinating in a grim way how the cancer statistics just mirror the broader health trends of the population. It's not just about viruses anymore.
It's all connected. But before we move off causes, we have to touch on what the sources call the rogues gallery.
Oh, I love a good rogues gallery.
These are the high-yield associations that might not be as common as Hep B, Hep C, or alcohol. But they invariably show up on exams and in those tricky diagnostic puzzles.
Okay, let's run through them. First one on the list, aflatoxin B1. This sounds like something out of a spy novel.
It does, doesn't it? Aflatoxin. It's actually a potent carcinogen produced by a fungus, Aspergillus flavus.
And where do we find this fungus? It's not just floating in the air, I assume.
No, it grows on improperly stored grains and nuts, things like corn, peanuts, soybeans. In distinct parts of the world, particularly parts of Africa and Asia where grain storage is difficult because of the heat and humidity, the fungus just thrives.
So it's an environmental contaminant. You eat it.
You eat it, You ingest the toxin, it goes to the liver, and it causes a very specific mutation. It targets the p53 tumor suppressor gene.
P53, that's the guardian of the genome, right?
That's the one. It's the gene that stops tumors from forming. Aflatoxin specifically targets codon 249 of the p53 gene. It just knocks out the guardian.
Wow.
It's incredibly specific molecular pathology.
That is wild. Okay, next up, hemochromatosis.
This is often called bronze diabetes in the older textbooks. It's a genetic condition, autosomal recessive, where your body absorbs way too much iron from your diet.
The regulator's broken.
The regulator's broken, and the body has no way to actively excrete excess iron, so it just stores it. And it stores into the liver, the pancreas, the skin, the heart. But the liver gets hit really hard.
And I'm guessing iron is toxic to liver cells in those amounts?
Extremely toxic. Iron generates free radicals through something called the Fenton reaction. It causes massive oxidative stress. It's like rusting your liver from the inside out.
Wow.
That chronic damage leads to cirrhosis and carries a very, very high risk for HCC, one of the highest relative risks among all the liver diseases.
Okay. We also have Wilson disease on the list here.
Similar concept to hemochromatosis, but instead of iron, it's copper. A genetic defect prevents the liver from excreting copper into the bile. So copper accumulates, causes damage, cirrhosis, and then cancer.
And primary biliary cholangitis.
That's an autoimmune disease. Your own immune system attacks and destroys the small bile ducts inside the liver.
So the bile can't get out.
It can't get out, so it backs up. And bile salts are disurgents. They're toxic to cells. So you get chronic inflammation, cirrhosis, cancer.
Yeah.
You're sensing the theme here, right?
Chronic injury leads to cirrhosis, leads to cancer. It's the same story.
It's the same final common pathway.
And the last one on this high-yield list caught my eye because it seems different. Anabolic steroids.
Yes, the USMLE favorite, as our source calls it. Long-term, high-dose use of anabolic steroids can cause liver tumors. Often they cause benign ones, like adenomas. But those can transform, or they can be associated with HCC directly. It's a really crucial history question to ask, especially in a young muscular patient who comes in with a liver mass and doesn't fit the typical viral or alcoholic profile.
Okay, so we've set the stage. We have the soil, usually cirrhosis. We have the seeds, viruses like Hep B and C, fatty liver, toxins like aflatoxin, genetic iron overload. Now let's move to section 2, the detective work.
Right, because knowing the risk factors is only half the battle. You have to catch the killer before it strikes.
Screening. In many cancers, we talk about mammograms or colonoscopies. What is the protocol for the liver?
The protocol is remarkably standardized, and that's because the risk population is so well defined. We screen the people we know are at risk.
So that means everyone with cirrhosis.
Everyone with cirrhosis, no exceptions. Doesn't matter if it's from alcohol, Hep C, fatty liver, whatever. If you have cirrhosis, you have bad soil, you get screened.
And going back to our earlier point, we also screen certain hepatitis B carriers.
Yes, very specific subsets of Hep B carriers. Asian males over 40, Asian females over 50, African carriers over 20, and anyone with a family history of HCC. We screen them even if they don't have cirrhosis yet.
Because of that DNA integration risk?
Exactly.
And the tool of choice. I was surprised it wasn't a CT scan right off the bat. The sources all say ultrasound?
Correct. Ultrasound is the screening modality, and we do it every 6 months.
Why ultrasound? Isn't CT, a better picture?
Well, it's a much better picture, for sure. But CT involves radiation and contrast dye. If you're screening someone for 20 years, you don't want to bombard them with radiation twice a year. Ultrasound is cheap, non-invasive, has no radiation, and it's good enough to spot a new lump.
And why every 6 months? Why not once a year?
It's all based on the biology of the tumor. The doubling time of HCC ranges, but typically it takes about 6 months for a tiny, undetectable lesion to grow into something we can see but is still treatable, say around 1 to 2 centimeters.
I see.
If you screen every 6 months, you're very likely to catch a lesion when it's still small enough to be cured. If you wait a year, it might grow from 1 centimeter to 5 centimeters or invade a vein, and then it might be too late.
It's all about that window of opportunity.
Exactly.
Now let's talk about the blood test. AFP, alpha fetoprotein. The sources call this a debate. So why is it a debate? Is it useful or not?
It is.
Yeah,
Imperfect. Let's look at what AFP is. It's a fetal protein. It's produced by the yolk sac in the fetal liver. Normally, your liver stops making it after you're born. In adults, the levels should be very, very low.
So why does it come back in cancer?
Because cancer is often a process of dedifferentiation. The cells kind of revert to a more primitive fetal state, so they start cranking out fetal proteins again.
So if it's high, it's bad.
Generally, yes. A value over 400 nanograms per milliliter is strongly suggestive of HCC. If you see an AFP of, say, 1,000, it's almost certainly cancer. But here's the catch, and the reason for the debate. 30 to 40% of HCC cases have completely normal AFP levels.
Wow, so nearly half the time the blood test could say you're fine when you actually have a tumor.
Exactly. It has very low sensitivity, and that is why we never, ever rely on AFP alone for screening. It's always paired with ultrasound.
I see. That makes sense.
And honestly, a rising trend is often more scary than a single high number. If a patient's AFP goes from 5 to 20 to 50 over the course of a year, even if it hasn't hit that 400 mark, you should be very, very worried. That velocity tells you something is growing.
The source also mentioned something called the AFP-L3 fraction. Is that just a more precise version?
Yes, that's a duplicate. It's a specific isoform of AFP. It turns out that AFP-L3 is more specific for the cancer itself, whereas the total AFP can sometimes be elevated just from liver inflammation or a hepatitis flare.
So it cuts through the noise.
It helps cut through that noise. It's becoming more common in refined screening protocols, especially in Japan and increasingly in the West.
Okay, so the ultrasound picks up a shadow, a spot, where the AFT is climbing. Now we get to the part that blew my mind in the intro. The magic trick, the non-invasive diagnosis. You said earlier that HCC is the only solid organ tumor we treat without a biopsy.
It is a remarkable thing. I mean, think about breast cancer. You see a lump on a mammogram? What do?
Biopsy it?
You biopsy it.
Yeah.
You have to know if it's ductal, lobular, hormone receptor positive, all of that. You never do a mastectomy based just on a mammogram.
Right.
In HCC, if the picture is right, we trust the picture. We treat based on the scan.
So what are the criteria? How can we be so sure just by looking at a CT or an MRI?
You need three things to align. First, the context. A cirrhotic liver. This rule generally only applies if the patient has cirrhosis or chronic Hep B. If a random, healthy 20-year-old has a liver mass, you're going to biopsy that. But in a cirrhotic liver, the probability just shifts so heavily.
Okay, context is key. Got it.
Second, the lesion must be bigger than 1 centimeter. Tiny sub-centimeter dots are just too hard to characterize.
Then
Third, and this is the most important part, it has to show a specific behavior on a multi-phase CT or MRI scan. We call this the triple phase study.
Triple phase. Okay, walk us through this. It's not just taking one picture, it's a sequence.
Exactly. To understand this, you have to understand the blood supply of the liver. The liver is totally unique because it has a dual blood supply.
The portal vein and the hepatic artery.
Right. The normal liver gets about 75% of its blood from the portal vein. That's blood coming from your gut, rich in nutrients but lower in oxygen. It only gets about 25% from the hepatic artery. So the normal liver parenchyma is portal dominant.
Okay, so the normal liver is mostly portal fed.
But HCC is a tumor. And like a lot of tumors, it's hungry. It undergoes angiogenesis. It builds new blood vessels. But here's the critical physiological crick. It doesn't hook up to the low-pressure portal vein. It hooks up to the high-pressure hepatic artery. It hijacks the arterial system.
I see where this is going. The contrast dye we inject.
Yeah.
It's going to hit the arteries first, right?
Precisely. So let's look at the scan phases. Phase 1 is the arterial phase. You inject the contrast into the patient's arm vein. It goes to the heart, gets pumped out the aorta to the liver arteries. This happens fast, like 20 to 30 seconds.
Okay.
Because the tumor is feeding almost exclusively from the artery, it just sucks up that contrast immediately. It lights up bright white.
So the tumor glows while the rest of the liver, which is still waiting for the portal blood, is relatively dark.
Exactly. We call this arterial phase hyperenhancement, or APHE. It's a light bulb in the dirt room. That's step 1.
And then, what happens next?
Then comes phase 2, the portal venous phase. This is about 60 to 70 seconds later. The contrast is circulated through the gut, and it's now coming back to the liver through the portal vein. Now, the normal liver tissue, which loves portal blood, lights up as it soaks in the contrast.
But what happens to the tumor?
The tumor has already used the arterial blood. It has no portal supply, so the contrast washes out of the tumor. The tumor becomes dark again, while the surrounding liver becomes bright. We call this washout.
It flips completely.
It flips.
Yeah.
Light on dark, then dark on light. That pattern arterial enhancement plus portal washout is pathognomonic. It is the fingerprint of HCC.
And if you see that, you don't need a needle.
If you see that in a cirrhotic liver, you are 99% sure.
Is there a reason we avoid the biopsy? Is it just because we can? Or is there actually a risk?
Oh, there is a risk. I mean, putting a needle into any tumor carries a risk of bleeding.
Yeah.
Remember, cirrhotic patients often have bad clotting because their liver isn't making the clotting factors.
Right.
But uniquely for HCC, there is a risk of tumor seeding.
Seeding, what's that?
You can actually drag cancer cells out along the needle track as you pull the needle out.
Yeah.
You can implant them in the abdominal wall or the peritoneum.
Oh, wow.
You can turn a localized cancer into a metastatic one. It's rare, maybe 2 to 3%. But why on earth would you take that risk if the scan tells you the answer with near certainty?
That is fascinating. It's like trusting a fingerprint at a crime scene so much you don't even need to interview the suspect because you don't want to risk him escaping during the interview.
That is a perfect analogy. And we formalize this confidence with a system called LIRAD,
LRS.
Liver Imaging Reporting and Data System. It's a standardized score radiologists use. LIRADS 1 is definitely benign. LIRADS 5 is definite HCC. If a radiologist puts LIRADS 5 on a report, that is a diagnosis. The next step is treatment.
Which brings us perfectly to Section 3, the 3 pillars of decision-making. Because as you said, finding it is one thing. Deciding what to do seems vastly more complicated.
It is, because you're fighting that war on 2 fronts.
Yeah.
This is the unique challenge of HCC. In most other cancers, say colon cancer, you just worry about the tumor. Is it big? Has it spread? Can I cut it out? In HCC, you have to worry about the tumor, and you have to worry about the liver function.
Right, because of the cirrhosis. You can't just cut out a chunk of liver if the liver is already barely holding on.
Exactly. You might cure the cancer, but kill the patient from liver failure 2 weeks later. So we need frameworks to balance these 2 competing interests. We need to assess the soil, and we need to assess the seed.
Okay, let's start with the first framework, the Child-Pugh score. This is all about assessing the liver itself, the soil, right?
Yes, this is the measure of the soil. How much reserve does the liver have? The score uses a mnemonic, A, B, C, D, E. It's been around for decades, but it still works remarkably well.
Okay, let's unpack A, B, C, D, E.
A is for albumin. The liver makes albumin, the main protein in your blood that holds fluid in the vessels. If your albumin is low, the liver synthetic function is failing. B is for bilirubin. If the liver can't clear bile, bilirubin goes up. You get jaundiced. C is for clotting, specifically PT or INR. The liver makes almost all the clotting factors. If you can't clot, your liver is in deep trouble.
Right.
D is for distension, which refers to ascites fluid in the belly. This happens when the liver is scarred and pressure builds up in the portal vein. And E is for encephalopathy. This is confusion caused by toxins like ammonia that the liver isn't filtering out.
So you look at these 5 things, albumin, bilirubin, clotting, distension, encephalopathy, and you get a score.
Right. You add up the points, and that score puts you into a class. Child class A means the liver is working pretty well. It's compensated. Child class B is moderate dysfunction. And child class C means the liver is decompensated. It's failing.
And the so what here? How does this change the plan? What's the bottom line?
The so what is surgery. If you are child A, we can probably operate. We can cut out the tumor because the remaining liver is strong enough to handle the stress and keep you alive. If you're a child C, surgery is absolutely contraindicated.
Off the table.
Completely off the table. If you touch that liver, the patient will die of liver failure on the table or in the ICU.
It's a red light, green light system.
Exactly. It sets the absolute ceiling for what is possible.
Okay, so that's the liver function. Now let's look at the tumor. We have the Milan Criteria. The source calls this the gatekeeper to transplants.
This is one of the most famous studies in the history of surgery. Dr. Mazzaferro from Milan published this in the New England Journal of Medicine back in 1996. Before this criteria, liver transplants for cancer had just awful outcomes. Surgeons were transplanting people with huge tumors, and the cancer would just come back in the new liver or spread to the bones within months. It was a waste of precious organs.
So they needed a rule to figure out who would actually benefit.
Right. They looked back at their data, and they found that if you stay within these very strict limits on tumor size and number, the survival is amazing, like 70% at 5 years. That's comparable to transplanting someone for just cirrhosis without cancer.
And what are those limits? This is the Milan box we have to fit inside.
It's the rule of 1 or 3. You can have one tumor that is less than or equal to 5 centimeters, or you can have up to 3 tumors, provided each one is less than or equal to 3 centimeters.
1 under 5 or 3 under 3.
Plus, obviously, no invasion of the blood vessels and no spread outside the liver.
If you fit inside this box, the Milan box, you get a transplant.
You become eligible for a transplant, and a transplant is really the holy grail of HCC treatment.
Why is it the holy grail? Is it better than just cutting the tumor out?
Well, think about it. We said the problem is a war on 2 fronts.
Yeah.
The tumor and the cirrhosis.
Right.
If I just cut out the tumor, which we call resection, I leave the cirrhosis behind. The soil is still bad. the cancer can come back, and recurrence rates after resection can be 50–70%.
Wow.
A transplant solves both problems instantly. You take out the tumor, and today you take out the cirrhotic liver that was generating the tumor. You replace the bad soil with fresh soil. It is the only treatment that is theoretically a total cure for both diseases.
That is powerful. But obviously, organs are scarce. We don't have enough livers for everyone. So the Milan criteria have to be incredibly strict to make sure those organs go to people who will actually survive.
Exactly. It's a utilitarian calculation.
Yeah.
If you are outside Milan, say you have a 10-centimeter tumor, we know that even if we give you a new liver, the cancer is likely already microscopic in your blood. It will come back. So we don't waste the organ.
Brutal, but necessary logic.
It is.
Okay, we have Child-Pugh for liver function. We have Milan for transplant eligibility. Now we need the master map that puts it all together. The BCLC staging, Barcelona Clinic Liver Cancer.
BCLC is king. In other cancers, we use TNM, staging tumor, node, metastasis. In liver cancer, TNM is almost useless because it ignores the cirrhosis.
It only describes the seed.
Right. It tells you about the seed, but ignores the soil. BCLC is genius because it integrates everything. The tumor stage, the liver function using Child-Pugh, and the patient's performance status, how fit they are.
So it links the stage directly to the treatment. It's not just a prognosis tool, it's an action plan. Let's walk through the stages quickly.
Sure. Let's start at the best case. Stage 0, or very early stage. This is a single lesion, less than 2 centimeters.
Tiny, what do we do?
Resection, you cut it out, or ablation, you burn it. It's curative. Then stage A, early stage, this is where Milan comes in, single nodules or up to 3 nodules under 3 centimeters. If they have good liver function, a child A, we resect. If the liver is bad, child B or C, but they meet Milan, we list them for transplants.
Okay. Moving to stage B, intermediate.
This is multinodular, lots of tumors, large tumors, but the liver is still working okay and there's no spread to the veins. Here, we can't cut them all out. It would be too much liver to remove, so use TACI. Transarterial chemoembolization.
We'll dig into that procedure in a minute. Then stage C.
Advanced. This means the cancer has invaded the portal vein, which is vascular invasion, or it's spread to bones or lungs. At this point, local therapies like surgery or TACE don't work well or are dangerous. We need systemic therapy, drugs.
And finally, stage D.
End stage. And this is usually determined not by the cancer, but by the liver failure. A child class C patient. They're very sick, maybe bedbound. The treatment here is palliation, comfort care.
It's a very orderly descent. It tells you exactly where you stand and what to do.
It does. It removes so much of the guesswork.
So we've mapped out the decisions. Now let's get into the treatment arsenal itself. Section 4. I want to talk about the math of safety in surgical resection, because you can't just hack away at the liver.
Ah, yes. The concept of the remnant, the future liver remnant, or FLR.
The notes say normal liver requires 25–30% remnant. What does that mean?
It means if you have a healthy liver, say you were in a car crash and tore it, a surgeon could remove 70–75% of your liver, and the remaining 25% would grow back and keep you alive.
Wow.
The liver is the only organ that regenerates like that. It's Promethean, really, like the Greek myth.
But we are not dealing with healthy livers here.
Right. We're dealing with cirrhosis. The soil is tired, it's fibrotic, it can't regenerate nearly as well, so the math changes. If you have a cirrhotic liver, you can't leave just 25%. You need to leave at least 40% of the liver volume behind.
So you can only cut out a maximum of 60%.
Correct. And if the tumor's big, removing it might take more than 60% of the liver volume. Then you're stuck. You can't operate because the patient will go into what we call post-hepatectomy liver failure.
But wait, the notes mention a workaround? Portal vein embolization, or PVE.
Okay.
This sounds like science fiction.
It is one of the coolest strategies in surgery. It's all about manipulating the body's own physiology.
Okay, walk me through it.
Let's say you have a tumor on the right side of the liver. You need to remove the whole right lobe, but the left lobe, the part you're going to keep, is too small. It's less than that 40% safety margin. It's too weak to support the patient.
So normally you'd have to cancel the surgery.
Normally, yes. But with PVE, we play a trick. A few weeks before the surgery, an interventional radiologist goes in and they plug up the portal vein that feeds the right side, the side with the tumor.
You cut off the food supply to the bad side?
You cut off the portal flow. So what does the body do? It shunts all that nutrient-rich blood to the left side. The left side gets this massive influx of growth factors, and it starts to grow. It hypertrophies.
So you're telling me you can force the good side of the liver to bulk up before the main event?
Exactly. You wait 4 to 6 weeks, do another scan, measure it again. Often, that left lobe has nearly doubled in size. Once it hits that 40% safety margin, you take the patient to the OR and remove the right side. The right side is actually shriveled a bit, which makes it even easier to remove.
That is absolutely brilliant. It's like training for a marathon before you actually run it.
It is physiological manipulation at its finest. It expands the number of patients we can actually cure.
Okay, let's talk about the other acronym we dropped. TACE, trans-arterial chemoembolization. This relies on that dual blood supply hack again, doesn't it?
It does. Remember we said the tumor eats from the artery and the liver eats from the portal vein.
Right.
TACE exploits that. This is for those patients who have too many tumors for surgery, BCLC stage B. We snake a catheter up through the groin, into the hepatic artery, right to the feeder branch of the tumor. Then we inject a super high dose of chemotherapy directly into the tumor.
So it's targeted chemo. You're not flooding the whole body with it.
Exactly. High local concentration, very low systemic side effects. But we don't stop there. After the chemo, we inject an embolizing agent like tiny beads or gel foam that physically blocks the artery.
So you poison it and then you choke it.
We poison it so the drugs stay inside, they can't wash out, and then we choke off the blood supply to create an ischemic environment. The tumor starves and dies. It infarcts.
But what about the surrounding liver? Doesn't it die too?
The surrounding liver is fine because it's still getting fed by the portal vein. The tumor dies because it only has the artery. The liver survives because it has the backup supply.
That is just incredibly elegant.
It is, but there is a huge catch. You can only do this if the portal vein is open.
Ah, right. If the patient has a portal vein thrombosis, a clot or tumor invasion in the main vein, you can't block the artery too.
Exactly. If you block the artery when the portal vein is already closed, you've just cut off all blood to the liver, the patient dies of acute liver necrosis. So portal vein thrombosis is a hard contraindication for TIS.
Understood. Now, what about when we run out of local options? Stage C, systemic therapy, the drugs.
For a long time, this was a pretty depressing field. From about 2007 until 2018, we really only had one drug, sorafenib. It's a tyrosine kinase inhibitor. It worked, but not great. It added a few months of survival, and it had really tough side effects, hand-foot syndrome, diarrhea.
But things have changed a lot recently.
Drastically. We have entered the era of immunotherapy.
The notes highlight atezolizumab plus bevacizumab. That's a mouthful.
We call it atezobev. It's the new standard of care first line. It changed the game in a trial called Embrave 150.
Okay, so what do they do?
Atezolizumab is a checkpoint inhibitor, an anti-PD-L1. It basically takes the brakes off the immune system, allowing your T cells to attack the cancer. And bevacizumab is an anti-angiogenic, an anti-VEGF. It stops the tumor from growing new blood vessels.
So we're attacking the immune evasion and the blood supply at the same time.
Yes, and the bevacizumab also seems to help normalize the blood vessels so the immune cells can actually get into the tumor. It's a real synergy. Together, they offer significantly better survival and quality of life compared to sorafenib.
It's good to hear there is progress. Now, I want to veer off the main road for a bit. We've been talking about standard HCC, the cirrhotic older patient, but Section 5 of our outline covers the outliers, the weird cases.
These are the ones that make you look twice, the ones that just don't fit the pattern.
First up, fibrolamellar HCC.
This is the mirror image of classic HCC.
How so?
Well, think about the typical HCC patient, 60 years old, history of cirrhosis, high AFP.
Got it.
Now flip all of that. Fibrolamellar HCC happens in young people, 20 to 40 years old, even teenagers.
Young. Oh.
They have no cirrhosis. Their liver is healthy, and their AFP is usually normal.
It's the complete opposite profile.
And visually, on a scan or pathology, it has a very distinct look. It has a central fibrous scar. It kind of looks like a sliced orange with a white center.
A scar in the middle.
Yes. But here's a little nuance for the radiology nerds listening. Focal nodular hyperplasia, or FNH, which is a common benign lump, also has a central scar. But in FNH, the scar might enhance. It might light up on delayed phases. In fibrolamellar HCC, the scar does not enhance. It stays dark.
That is a detail that literally saves lives. And generally, the prognosis for fibrolamellar is better.
Much better. Because these are young, healthy patients without cirrhosis, we can be very aggressive with surgery. We can take out huge chunks of liver because that remnant regenerates percolate. We can really go for a cure.
Next outlier. The kids. Hepatoblastoma.
The most common liver tumor in children under 5. If you see a liver mass in a toddler, you have to think hepatoblastoma.
Are there specific associations we should look for?
Yes, genetic syndromes. Beckwith-Wiedemann syndrome, which is an overgrowth syndrome, big tongue, big organs, and FAP, which is familial adenomatous polyposis.
And the marker here, AFP.
The AFP is sky high. We are not talking 400, we're talking hundreds of thousands.
Wow. Got it. And the last group of outliers, paraneoplastic syndromes. This is when the tumor starts producing hormones or chemicals that mess with the body's metabolism remotely. The notes call this USMLE gold.
Oh, examiners love this because the patient presents with something really weird and you have to work backwards to the liver.
Let's just list the symptoms. First, hypoglycemia.
Low blood sugar. 2 reasons for that. The failing liver can't store glycogen, so you can't fast. And the massive tumor is literally eating all the glucose because it has such a high metabolic rate. It's the Warburg effect on overdrive.
Okay. Polycythemia, high red blood cell count.
The tumor produces erythropoietin and EPO, the same stuff cyclists use to dope. It stimulates the bone marrow to make more blood, so the patient looks fleshed, what we call plethoric.
Hypercalcemia.
High calcium. The tumor produces a protein that mimics parathyroid hormone. It's called PTHrP, and it leaches calcium from the bones into the blood.
And watery diarrhea, that seems random.
It's rare. Sometimes they can produce VIP or vasoactive intestinal peptide.
So if a patient walks in with low sugar, high red blood cells, high calcium, and a tender liver,
You stop looking for weird endocrine diseases and you scan the liver. It's HCC acting like an endocrine organ.
incredible how the body can signal distress in these ways.
It really is.
We have covered a tremendous amount of ground. From the viral origins to the triple phase scans, the math of resection, and the immunotherapy revolution.
As we wrap up, I want to bring it all back to that unifying principle.
The exam gold principle.
Right. You said earlier that everything is a balance.
It is. If you take nothing else away from this entire deep dive, remember this. HCC management is a tug of war between tumor burden and liver functional reserve.
Give us the examples again to really cement it.
Okay. Small tumor, but a really bad liver. You can't cut. You need a transplant to replace the liver.
Big tumor, but a good, strong liver. You can cut, you can resect, but you have to worry about that remnant volume. Bad tumor and a bad liver. You're limited to palliation. Every decision, every guideline like BCLC or Milan is just a way of quantifying that balance.
It's the logic of the litter.
That's it, exactly.
So let's do the final recap, the high yield 5. The 5 things our listener absolutely needs to burn into their brain.
Number 1, 90% of HCC arises in cirrhosis. It is the disease of the damaged liver.
Number 2.
Hepatitis B is the great exception. It integrates into DNA and can cause cancer without cirrhosis.
Number 3.
Diagnosis does not require a biopsy. You look for arterial enhancement plus portal washout.
Number 4.
The Milan Criteria determine who gets a transplant. 1 tumor under 5 centimeters or up to 3 tumors, each under 3 centimeters.
And number 5.
The BCLC staging system is the master map that links the stage directly to the treatment.
Bam! There it is.
Simple when you break it down that way.
You know, for my closing thought, I just keep going back to that diagnostic criteria, the idea that we trust the LI rod's imaging so much that we don't need a biopsy.
It really is unique in all of medicine.
It speaks to the vascular nature of this tumor. It's a cancer that is defined by its hunger for blood. It builds its own arteries, it lights up on the screen, and that greed is exactly what gives it away.
That is a very poetic way to put it. Its strengths, that arterial blood supply, is also its Achilles heel, both for diagnosis and for treatments like TACE.
And for anyone listening, whether you're prepping for a board exam or just trying to understand a diagnosis for a loved one,
watch the liver function. Don't just stare at the tumor size. The health of the liver is the absolute ceiling for what we can do. You have to protect the liver.
wise words. Thanks for breaking all this down with me.
My pleasure.
And to our listeners, thanks for diving deep. We'll see you on the next one.